Hello, everyone. You might remember my thesis topic, investigating the accuracy of artificial intelligence used for caries diagnostic. My name is Bruna. I'm a dentist. My supervisor is Marton Kivovic, and my SMS is Alex. My vision is making high-end dental diagnostics accessible to the public, and my mission is applying artificial intelligence for community dentistry. Here we have our specific goals. The first one is investigating the accuracy of artificial intelligence used for approximal caries diagnostic, and the second one is investigating the accuracy of intraoral scanners used for caries diagnostic. For the first project, we performed a systematic review and a meta-analysis. And according to the background, the direct cost of dental caries is more than $200 billion a year, and the caries is still affecting people population, especially approximal caries. Considering biting radiography as a standard, to have a good accuracy can reduce the complex cases. In addition, the literature shows disagreement between experts about caries diagnostics on biting radiographies with a sensitivity range between 0.5 and 0.7. On the other hand, artificial intelligence can increase the early detection with a sensitivity ratio of about 0.85. Our aim is investigating the diagnostic accuracy of artificial intelligence for approximal caries lesions on biting radiographies. Our clinical question is, what's the accuracy of artificial intelligence used for approximal caries diagnostic on biting radiographies? As population, we chose patients undergoing biting radiography as index test, artificial intelligence, as reference test, experts consensus, and as diagnostic the accuracy. After performing the systematic search and the selection, we had 21 full eligible articles. And here we have our final results. And we chose sensitivity and specificity as outcomes. They are important to understand if the index test is comparable to the reference test. And as we can see, the results favor artificial intelligence, and they are above experts' threshold. And also, the negative predictive values were moderate to high, and the negative likelihood ratios were low. That means artificial intelligence strength is to exclude true negative answers. And also, the positive likelihood ratios were above 1. That means artificial intelligence is a reliable test. Here we have the HS rock plot. This is a hierarchical summary of the accuracy, and as we can see, most part of our articles were included in the confidence ratio. We also can see how high the heterogeneity is, what can be explained for some reasons as different artificial intelligence models, different sample sizes, and different learning ratings. As strengths, we would say this is the first meta-analysis about the topic with the correct use of artificial intelligence models, and we included only RCTs and no RCTs. As limitations, we'd say the fuzzy gold standards, the low quality of reporting, and the lack of raw data that made it impossible to compare the accuracy between experts and artificial intelligence. As conclusions, we say artificial intelligence sensitivity and specificity are high for detecting approximal caries lesions on biting radiographies, and according to the negative predictive values and the negative likelihood ratios, its strength is to exclude true negative answers. As implication for practice, we recommend artificial intelligence should be used as a preliminary step, followed by experts diagnostic. As implication for research, we suggest trials reporting should be more transparent, raw data should be available, and a ground truth should be established. Our manuscript was already published. And for the second project, we performed a systematic review and a meta-analysis as well. And according to the background, caries is the most common non-communicable disease in the world and still affects people population. And the introduction of intraoral scanners can support the clinical decision and avoid the teeth loss. And also, the literature shows intraoral scanners result in equal or improved sensitivity in comparison to bilingual radiographies. Our aim is investigating the diagnostic accuracy of intraoral scanners for caries lesions. Our clinical question asks what's the accuracy of intraoral scanners used for caries diagnostics. As population, we chose extracted teeth as index test, intraoral scanners as reference test, histological assessment or micro-CT, and as diagnostic the accuracy. After performing the systematic search and the selection, we had 5 full eligible texts. And here we have our final results. And for sensitivity and specificity, we had moderate numbers, and they are comparable to a micro-CT threshold, and they are under the histological assessment threshold. We also can see the presence of 2 outliers that reflects the presence of some differences among the methodologies. Besides the positive predictive values were moderate to high, the negative predictive values were very wide. That means intraoral scanners' capacity of identifying true negative answers can vary. Regarding the likelihood ratios, the positive one was moderate and the negative one was wide. That means intraoral scanners are not a reliable test. For accuracy and heterogeneity, we can see most part of our articles were included in a narrow confidence radio, pointing to a moderate heterogeneity for specificity. For sensitivity, we can see a quite wide confidence radio, pointing to a high heterogeneity, what can be explained for some reasons as different intraoral scanner systems, different types of caries, and different pulled teeth, and the others. As strengths, we included histological assessment and micro-CT as gold standards, and we consider any type of caries. As limitations, only in vitro studies were included and in a few number. As conclusions, we say intraoral scanner sensitivity and specificity are moderate for detecting caries lesions, and according to the negative predictive values and negative likelihood ratios, they are not reliable. As implication for practice, we say intraoral scanners are not suitable for screening caries, and they should not be used alone. As implication for research, we suggest improvements for intraoral scanner systems and more standardized clinical studies. We are working on the issues from the internal review. And in summary, we have 2 projects. The first one was published last year, and the second one will be submitted soon. To say my goodbyes and finish my presentation, I would like to use a Paulo Freire quote. Education is an act of love, and therefore an act of courage. Thank you for your attention.
You mentioned that all kind of caries was included. You mentioned in the second project, but I don't remember in the first project. It also all kind of caries was included in the studies, or?
For the first one, we worked about the proximal caries lesions on bilingual radiographies.
Yeah, but I'm talking about the depths of the caries, so like superficial, medium, profunda, and so on.
All types were included. All types were included, so no matter what was the teeth.
Because usually the main problem is there are a scale like E1, E2, and D1, D2, and so on. So usually the problem is before the dentine reach. Then in that case, it's very difficult to make the diagnosis. So I wonder that is there enough data to make some kind of subgroup analysis and then just included those caries which is before the dentine reached, or because caries profunda can be diagnosed by anybody, even by a student, but but what is very important to diagnose the superficial, the medium caries. So is there any data about this?
For the second project, I think the question is about that. We saw intraoral scanners have a limitation for checking the deep caries when it is for the D1 and D2. So we have this data, but we couldn't use that because it was found only in one or in two studies. So we couldn't use two studies to build a data, to build a plot, for example, but we saw there is this limitation. But on the other hand, for more superficial caries in E1 or E2, it's more efficient.
It's interesting, and I'm just asking your supervisor that do you have a plan to introduce this system in our clinic or in the faculty? Because that's the translation medicine. I'm talking about the AI, not the intraoral scanner.
Thank you very much. Absolutely. Yes, we are working on several AI projects right now, and it would be wonderful to add or innovate and build a software for it.
But we use those software which already in
yes,
the publication.
It could be.
You know, we will have an increased number of patients from March, so it
yes,
would be very useful.
There are commercially available AI softwares for this, and I think that some departments of the university, at the oral diagnostic department, it is available. So comparative studies could be feasible. We'll see.
If I may ask, can the type of intraoral scanners have influence? Because as I saw that maybe it is 5 articles only, so could that have an influence? My second question maybe, how you were able to finish 2 projects in such a time? What are you doing? What are you eating?
Thank you for that. Regarding the first regarding the first question, yes, the intraoral scanner systems was one of the causes of the high heterogeneity, and it is influenced mainly for the wavelengths. We worked with smaller wavelengths as blue-violet wavelengths and infrared lights. They are bigger. So we saw with the minor wavelengths, the capacity of identify lesions is biggest, of course, because it's smallest and it can be deeply. For the near infrared one, the capacity is more limited, but there are more systems using this type of light. So it can explain one of the reasons for the heterogeneity, and we saw the differences were very, very clear. And for your second question, I think you need to have in mind your deadlines and working on your responsibilities, I think, and that's it.